I was just going to text you, say I had no control.
All right. Well, welcome everybody to the next session. It's already been two great sessions, and hopefully you've been able to catch it. We're talking about the Cavus foot and ankle in the athlete. We've got our brethren up north who are going to be taking us through this session. Tim Daniels will moderate, and Paragon 28 has been the generous sponsor for this event. Thanks.
Thank you, Selene. I've put together an all-Canadian panel for the international folks. We have Rachael Da Cunha from Kingston, Ontario. She's just starting her academic career in foot and ankle and trauma. Andie Veljkovic, who I think many of you know already. Rachel's going to talk about the physical exam radiographs and how that alters or how that influences her treatment. And he's going to talk about ankle instability in the presence of a cable varus deformity. Alastair is going to talk about end-stage arthritis with varus deformity of the talus, and I'll be talking about Taylor Valgus deformities. And of course, we're going to keep a sports theme here. So I'm going to hand it over to Rachael. Welcome, Rachael.
Thanks, Tim. Thanks for the invite and thanks for having me. So I'll jump right in so we can get to it. So I'm going to talk about the pes cavus reconstruction of when to osteotomize and when to fuse, and looking at physical and radiographic evaluation. No disclosures. So just to give an idea of where Kingston is. So I grew up in Alberta, in Edmonton and Calgary there. We have some of our panel here from Vancouver, Toronto, and then Kingston, little city just east of Toronto. We're right on Lake Ontario. So traded the mountains in Alberta for the lake here. So often we think of pes cavus etiology, lots of people just think of the neurologic, but I'm going to obviously focus on the idiopathic pes cavus foot, as that's more pertinent to our forum today. So when talking about the idiopathic pes cavus foot, you can have a primary hindfoot varus where you can have aberrant calcaneal or subtalar morphology, or forefoot driven hindfoot varus where you can get primary plantar flexion of the first ray, or an overactive peroneus longus, which essentially plantar flexes your first ray. And more pertinent also, I'm going to talk about the subtle cavus foot, as when I'm talking about athletes and in sports, that's something that's quite common. That's probably underdiagnosed and important to treat. So looking at the forefoot driven here, just as an example, shows the plantar flex first ray when it strikes the ground, how it shifts the hindfoot into varus as a compensatory mechanism. So the subtle cavus foot is a mild malalignment thought to be likely along the spectrum of normal. It's common and likely underdiagnosed. It's thought that up to 25% of the population probably has a subtle cavus foot, and up to 1/3 of patients with ankle instability or perineal tendon pathology probably have some spectrum of a cavus foot. Definitely an increased incidence of injuries in athletes with the cavus foot compared to normal controls, and it requires a high clinical index of suspicion when you see athletes with particular injuries. So some of the associated conditions that we all know, so various stress factors, fifth metatarsal stress factors being the most common, which was what the last session was on, soft tissue injuries, perineal tendon pathology, chronic lateral ligament instability, plantar fasciitis, arthritis, and then other including sesamoid pathology or metatarsalgia. So when talking about the physical exam, we classically assess from the back to look for the hindfoot varus. You want to look at static and dynamic assessment. With subtle cavus foot, this is going to be not so obvious at times. The dynamic assessment may be more obvious, is when you have the patient do a heel rise. You may not see a significant inversion as they're already sitting in some varus. Looking from the front is actually probably a better test for that peekaboo heel sign for visualization, that medial heel pad with feet pointing forward. Coleman block test, look for forefoot driven versus primary hindfoot. Your silver skull to look for your gastrocnemius versus Achilles versus a mechanical block. Subtalar motion, your first ray, and in particular the activity of perineus longus, and then looking for various plantar callosity, Schuher pattern, et cetera, to tip you off. So these two drive treatment the most, as well as your silver skull. So just to kind of look at the poster hindfoot assessment, this is probably a more obvious one where you have a hindfoot and varus. But looking from the front, you can see here in particular that little peekaboo heel, just looking at that medial aspect of the calcaneal fat pad. Coleman block, which we all know, and the silver skull as well. So plantar flex first array, so it can be a primary plantar flex first array versus secondary to perineus longus overdrive. So to try to elicit that perineus longus overdrive, if you're not sure if that's present, you have the patient in a seated position, extend their knee and dorsiflex their ankle, and then ask them to actively plantar flex. And by putting pressure on the plantar aspect of the first metatarsal head and the lesser metatarsal heads, you can see if there is excessive plantar flexion, in particular that first, to guide you. The radiographs, I feel, are really an adjunct to physical exam. Obviously, you want your weight-bearing views. Confirm some of your physical exam findings of that plantar flex first ray, hindfoot bears, and what the apex of deformity is. Look for presence of degenerative joint disease, assess for any extrinsic deformity. So rather than if you think it may not be all secondary to a pes cavus from the foot, look for the ankle involvement or potentially more proximal, and assess for those associated conditions, and that being a tip off to looking for that pes cavus foot. So we don't need to go through all the angles here, but some of the classic ones on a lateral be to look for that talo first metatarsal angle, your arch height, calcaneal pitch, Hibbs angle, that posterior fibular position, sinus star see-through and bell-shaped cuboid, AP foot, looking at your tail calcaneal angle in particular, your saltzman hindfoot view can be quite helpful. And then it would include that standing full length hip to ankle radiographs if you suspect another pathology, and your ankle views. So just to kind of show some of those angles there, including the arch height, calcaneal pitch, Hibbs angle, and the talo first metatarsal angle. More recently, there's been the advent of weight-bearing CT. So there's limitations in weight-bearing radiographs. Obviously, it's dependent on projection, port orientation, and can be difficult to assess the 3D relationships. Conventional CT doesn't allow for full weight-bearing or physiologic loading. Even simulated weight-bearing CTs only achieve about 70% weight-bearing, and they're not physiologic. So the weight-bearing cone beam CT really helps to allow physiologic loading. It gives image quality comparable to conventional CT, and is much less radiation than a conventional CT. Still more than a plain radiograph, but not significantly. So it really gives you a better 3D orientation. It's introduced new hindfoot alignment measures utilizing various softwares. It can really aid in the diagnosis of that subtle cavus foot. Some work has been done looking at patients with chronic lateral instability versus controls, and they have notably more Varus and multiple parameters than controls. And this can really be an adjunct to guide treatment in patients with pathologies such as chronic instability or other associated pathologies where we're maybe under treating that cavus foot. So when to osteotomies or when to fuse, things that are important to look at, we're going to put together that physical exam as well as the radiographs. So typically we're going to have a patient that presents with an associated condition of a cavus foot. That may be a fracture, instability, perineal tendon, sesamoid, or what have you. That should tip you off to assess for pes cavus. Look for that positive peekaboo heel. If it's not evident posteriorly, do your Coleman block. Positive Coleman block means forefoot driven. Look for your first ray. If you think it's a primary plantar flex first ray, then my treatment is I do a longus to brevis transfer and a first metatarsal dorsiflexion osteotomy. If it seems to be overactive perineus longus, then start with a transfer and then reassess intra-op, and then determine if you need that osteotomy. Primary hindfoot, if negative Coleman block, if it's flexible, no arthritis, I do my lateralizing calcaneal osteotomy, and then you have to assess your forefoot again, and plus those other adjuncts. If it's rigid or arthritis present, then I go down the arthrodesis pathway and determine if it's just a primary subtalar arthrodesis needed or a triple plus your other procedures. Then you want to assess the hindfoot as well. And typically I'd start with the hindfoot procedures. It's easier to assess your Varus intraoperative. So silver skull positive gastrocs contracture. I do a Strayer gastrocs recession, but there's obviously multiple you can choose from. Negative, then you want to assess is there impingement. No anterior mechanical block, tight heel cord, do your TAL percutaneous, most likely plus minus posterior capsular release if it's still tight. Mechanical block, address that first, and then assess your heel cord, and then go ahead and go down that pathway if needed. So let's look at just a couple cases. So 18-year-old female, she's a varsity high school rugby player in her senior year. She's going to play college, and she's trying out for the national team. She's had a primary complaint of pain to medial sesamoid and plantar first MTP joint ongoing for multiple years. Multiple orthotics help a little bit, but not a lot. She's previously seen 2 other people who said she has sesamoiditis and recommended a sesamoidectomy, which she's obviously hesitant for. On exam, she has significant colostomy into that first metatarsal head, pain on palpation there. She's a positive peekaboo heel, flexible hindfoot, and positive Coleman block. She seems to have a primary plantar flex first ray on exam and no equinus. MRI just shows that the sesamoid looks like it's having a repetitive microtrauma, no evidence of AVN or fracture. So this is her kind of subtle increase in talus metatarsal angle, bilateral. You can see also posterior displaced fibula. So she has a subtle cavus foot, presents with associated condition of that sesamoid oval, sesamoiditis. It's forefoot driven and plantar flex first ray. So she goes down this pathway here. So she got a longus tuberous transfer and a first metatarsal dorsiflexion osteotomy. When I do this osteotomy, alignment with the K-wire, plantar hinge left intact, and then I dial in the correction. So I do this physical exam maneuver intraoperative and resect more as needed until it's balanced, and I fix it with a compression staple. So that was the right side and the left side, and I did these bilateral simultaneous so that she could take minimal time off, and she was back to sport in 8 weeks. Second case, 36-year-old male, military special forces. His primary complaint is chronic lateral instability. He has multiple ankle sprains and daily instability. So he has a positive peekaboo heel, hindfoot varus, even on posterior exam, negative Coleman block, and his forefoot appears balanced, but his hindfoot is flexible in passive examination, and he seems to have an anterior block. So that's him, a bit subtle. It's relatively well aligned. His talar metatarsal angle, we can see his increased calcaneal pitch and that anterior impingement, and his varus on a Saltzman hindfoot view. So he kind of goes down this pathway here for me, and he gets, and same with here. So I start again with the equinus, addressing that, as that's easier to judge your varus once that's addressed. So I start with the ankle scope and debridement, dorsiflexion improved, no heel cord tightness, so stop there. Lawlers and calcaneal osteotomy, the forefoot remained balanced on my intraop assessment, and then modified rostrum for his ligament instability. You can see it's the alignment there. I do a straight lateral translation osteotomy as my choice. And then last case, 6-year-old female, relatively sedentary, but enjoys walking. Presents a primary complaint of pain to that fifth metatarsal. Didn't have a discrete fracture, but I did have an MRI showing evidence for stress reaction. So she's maybe on her way to a fracture. But she also complains of pain to other parts of her foot. She has positive equal heel, a relatively stiff hindfoot that doesn't fully correct to varus, some equinus there with a positive silver scold as well. And these are her radiographs where you can see that she has some evidence for arthritis. She's a little bit older and it's more rigid, so she goes down the pathway of fusion for me. So she got a gastric recession, and then she was a triple arthrodesis, and she's very happy with this. Her pain is completely gone. So take-home points: have a high index of suspicion for pes cavus in patients presenting with associated conditions, and look for that subtle cavus foot. The key physical exam findings, as we discussed, radiographic findings, and then the treatment algorithm of when and what to osteomize and when to fuse. Thank you.
Thank you, Rachel. That was excellent. I just have a few quick questions before we move on to Andie. I was impressed that although you mentioned the tendo Achilles, you only performed a tendo Achilles lengthening in the last patient that had relatively severe disease. What's the role of tendo Achilles lengthening in these forefoot-driven cable varus? You're on mute, Rachel.
Thanks, Tim. Yeah, I find sometimes we talk about it a lot with pes cavus, but I think it can be over talked about a little bit. So I find with the forefoot driven that, again, when the subtle cavus foot in particular, that it's not as predominant. And in the one case, I thought I was going to have to do something to his gastroc or heel cord, but once addressing the anterior impingement, it was addressed. So I find it's not as much of a factor.
I've had several patients referred to me that have had a tendo Achilles lengthening in the presence of subtle cable varus foot, and especially with some of those anterior degenerative changes or osteophytes at the ankle, and they've actually gotten worse because it's increased the impingement between the talar neck and the tibia. So I'm very careful about tendo Achilles lengthening. Alastair, I'm interested in your viewpoint on this.
Yes, I mean, I often will do tendo Achilles lengthening in the cable varus foot. It's often tight, but you really have to be careful about that anterior impingement, because the tendo Achilles is protecting the anterior ankle. And if you lengthen it, they actually can't protect the anterior ankle anymore. So you don't want to do a tendo Achilles lengthening without making sure that they have adequate dorsiflexion and a full anterior debridement. So sometimes folk will clean out between the tibia and the talus. They don't do the gutters. So it's really important to get those gutters cleaned out as well. So you want to have appropriate dorsiflexion before you do a heel cord lengthening.
Now, do you get rid of the talar bossing there, Alastair? Do you create a trough anteriorly? How aggressive are you?
Very aggressive. I make a really nice big trough across the front when I look at it through the scope, and I want to see that cartilage surface go right up and be able to get up underneath the tibia. The other thing is when you correct deformity, sometimes that can actually change things. So your heel cord may be, you may actually create impingement once you correct the hindfoot, and you have to be careful about that. So you got to do your assessment at the end of your reconstruction, not at the beginning.
I have to say I do tendon Achilles lengthening. It always surprises me when it's necessary, but in less than 10% of patients. And once again, I caution the audience to be very careful. Often when you read articles, they talk about tendon Achilles lengthening in these scenarios as if it has no consequence. But I once dealt with a police officer who had nothing but a tendon Achilles lengthening in that scenario, and she actually had to quit her job because she could no longer walk the beat. So I would caution the audience about overzealous tendon Achilles lengthenings in these deformities, particularly if there's anterior disease at the ankle joint level.
Hey, Tim, we have a question. Yeah. If a moderate cavus requires both midfoot osteotomies as well as posterior tib tendon transfers, where do you insert the posterior tib transfer?
So that sounds like a scenario where you've got CMT, some weakness of dorsiflexion. I mean, the midfoot osteotomy is required first. It's very important to make sure that post-tib tendon transfer is medial to the midline of the foot. So my bias is it's either in the medial or intermediate cuneiform. If I can get it there, I perform a slide on the post-tib tendon, which gives me, when you're doing the transfer, you just slide your finger up the interosseous ligament, and you can actually get another centimeter or 2 centimeters excursion on that post-tib tendon by taking the muscle belly off its distal insertion site. And then I try to get it as medial as possible. Any other comments from the panel?
Yeah, if I'm going anterior, I split it and I'll take one half down to tib ant and suture it into the tendon. I'll take the other half down to peroneus tertius. And in general, it tends to invert more than evert, so I make it tighter on the lateral side.
Thank you, Rachel. That was excellent. Andie is going to talk to us about managing ankle instability in the presence of a cable varus deformity. Thanks, Andie.
Thanks so much. Can you guys hear me, Tim?
Yep.
Great, perfect. Hi, guys. Thank you so much, Tim, for inviting me to this. I'm talking a little bit about chronic lateral ankle instability. And of course, I have to add a bit about alignment because it's me. In general, I have no disclosures for this talk. We'll talk a little bit about etiology, approach, cause for failure, investigations, and surgical strategies. What we know about ankle sprains is that it's one of the most common soft tissue injury. It accounts for about 40% of sports injuries. And these injuries are those that change direction, such as basketball, football, soccer, running, and volleyball. And you have a higher incidence of these ankle injuries. However, the incidence of chronic ankle instability after acute ankle fracture is reported between 5 and 70%. And to me, that's a really massive range, which tells me that it's fairly underreported. My approach in general is obviously having a good diagnosis, and that involves a meticulous physical examination and history, obviously the use of imaging to help you in terms of assessing the patient, a rehab program, and then when you can't get this patient to get stabilized with non-operative measures, you look at surgical stabilization. In general, the key for me, unfortunately, with these cable varus feet is you really need to think alignment. You got to think about why this is important, because you have a failure of the static components, and you also have a failure of the dynamic mechanisms to compensate. And I personally feel that if you don't have the static components intact, you can't expect the dynamic components to overcompensate. In general, when I'm thinking about soft tissues, I don't need an MRI to assess the ligaments in general. What I'm looking for is cartilage. I'm looking for the tendons, such as specifically the perineal tendons, and for cartilage damage that may have occurred. When it comes to ligaments, an MRI might be helpful in the extreme chronic setting to assess whether or not there's even tissue there. And this may inform upon the need to have allograft or autograft selection available. Here you can see that the MRI shows you a little bit about the perineal tendons, that there's perineal tendinopathy and how this is treated. And why it's important to think about this. So you can see here a patient with chronic cavus foot who we did tendoscopy on and has involvement of the perineal tendons. And this is nice because you can actually use arthroscopic techniques to deal with this and to deal with the problem-induced debridements. And if there's tears, you likely have to open up the situation. In general, when we think about chronic ankle instability, we think about predisposing factors, such as history of previous sprains. And of course, Rachel did an amazing job about talking about cava varus foot. And that's pes cava varus, as well as that dropped first ray. What we know is that there's a higher frequency of cava varus foot deformity in patients with chronic lateral ankle ligament instability as compared to controls. However, if you just do an isolated soft tissue reconstruction in these cases, you know that they often will fail if the deformity is not addressed. So what we've seen from the past is that there's several factors that have been shown to predispose patients to failure, specifically in these chronic ankle cases, and this is hindfoot malalignment. And why this is important is that when you have the patient with hindfoot malalignment or varus, it causes an increased supination moment around the subtalar joint axis. So you have a rigid supinated foot or calcaneal varus, and you get this laterally placed subtalar axis relative to the ground reaction force. And this increases the supination moment and causes excessive inversion and injury. So when you're thinking chronic ankle cases with cava varus, really think about the alignment and what you could change. Lots of procedures out there really when it comes to surgical management of lateral ankle instability. And in the past, we've discussed anatomic and non-anatomic procedures. We know that the non-anatomical procedures have lost favor. These have shown fairly good results from the standpoint of anatomic with 81 to 97.2 good results. However, we need to think about how to treat that spectrum of cavus. And Rachel did a great job with this, right? You want to first make sure, is it forefoot or hindfoot driven, or is it a combination of both? So in general, for me, this is the key. You want to see, is it forefoot driven? So you have this hindfoot varus present. You take your laterally based Coleman block test, and if it corrects, you know that it's got to be driven by the forefoot. However, if the patient puts a laterally based Coleman block test and that hindfoot doesn't correct, there may be either a component of both or hindfoot varus. And this kind of informs upon what you need to do surgically when you do your lateral ligament reconstruction. Here, as Rachel mentioned, you may do your first dorsiflexion osteotomy, soft tissue procedures such as the plantar fascial release. In the setting of chronic lateral ankle instability, I don't tend to do perineal transfers because I think that the perineals themselves are dynamic stabilizers. But if the perineus brevis is severely involved, I might consider doing a double level transfer, one above and below the ankle, and cable graft the brevis. And we'll show you this later in a case. However, if the patient has hindfoot malalignment, then you can think about doing a calcaneal osteotomy, plus minus something with the first ray if you think there's a component of forefoot drive, in addition to your soft tissue lateral ankle reconstruction. Obviously, if you're degenerative, you may need to do a lateral closing wedge subtalar fusion. So don't forget, if there's a component of varus of the ankle itself, consider doing distal tibial opening wedge osteotomy and fibular osteotomies. So goal of surgery is really to prevent recurrent giving away episodes. There's some evidence that instability predisposes to ankle arthritis, so we need to really think about stabilizing. When it comes to me, obviously you need to ensure it's straight. You want to mechanically align foot and ankle, and then you want to gain that concentric mortise of your soft tissue procedures and rebalancing. When we look at the outcomes of anatomic reconstruction, what we know is that there's fairly good outcomes with that, but non-anatomic reconstruction in the past has led to altered subtalar motion and late laxity. We know that these non-anatomic procedures have resulted in a decreased perineal reaction time and increased lateral foot loading. And this is important to me because it informs upon the importance of maintaining your perineals in a cava varus foot and reconstructing your perineals in a cava varus foot if they're involved. My approach usually is a broach and repair. I really detach everything from the fibula, but I augment. I use an ATF, I reconstruct the ATFL and CFL and then augment with the Gould if I need to. Biggest things when you're looking at chronic ankle instability really is there adequate tissue? Can I reconstruct? Do I need allograft or autograft? And that's something that maybe the MRI could inform upon, but you don't need the MRI to diagnose. Is this a high demand patient? Is there an increased size of the patient? Is there generalized ligamentous laxity? And what kind of malalignment am I dealing with in these cava varus feet? Because all of this has to be addressed, right? Coughlin and Mann looked at these allograft reconstructions in these chronic ankle instability patients, and they actually had fairly good results for these patients with improved AOFAS scores. Then you need to think, do I need to add a little bit of arthroscopy when it comes to my lateral ankle stabilization? Key thing here is you need to think to yourself, am I spending too much time in the OR? And do I need to do this as single or staged? And you know that if you go over 45 minutes, you may get too much induration of the soft tissues. Bea Hinterman told you why arthroscopy was important, because with these chronic ankle instability patients, there's a high amounts that had cartilage lesions, over 50%. In addition, I've mentioned it a few times, you really need to look at those perineal tendons. If you have perineal tendon involvement, you may need to modify your approach and deal with the perineals with either a repair or possibly a double level transfer. So here's an example of just a few cases that I have. This is a 45-year-old female, former basketball player. She had chronic ankle instability with ankle sprains 3 to 4 times a year. Severe sprain in 2016, and she was treated with physical therapy, ankle brace, and she's otherwise healthy. When you examine her, you can tell that she has a cava varus foot that's both forefoot and hindfoot driven, without full correction with a Coleman block test. She has significant laxity of her ligaments, both ATFL and CFL. She's quite tender along the perineals with some weakness of the perineals on the eversion. She has good tib post function, and she has features of anteromedial and medial gutter impingement as her predominant exam. Mild gastrocnemius contracture, and she has mild paresthesia of her SPM, likely due to these instability episodes. When you examine her here, you can see here that overall alignment is a bit of hindfoot varus, okay? She also has cavus of her midfoot. When you look at her MRI, you can see flattening of perineus brevis, which is actually quite extreme, as the perineus longus kind of cuts through that perineus brevis, like that, all the way down. And then as you go distal in the foot, you see disappearance of that perineus brevis. So really a near complete full thickness tear of perineus brevis, a chronic partial ATFL, badly visualized CFL. Here, same thing, doesn't show you the same examination, but at least it shows you some idea of what's going on. Again, brevis looks terrible. And similarly here, there's not a significant cartilage lesion, but again, loss of the lateral ligaments, you have some tissue to deal with at least, but a badly visualized CFL. Obviously, we tried non-operative measures. We did cava varus orthotics, trying to correct the hindfoot, giving lateral forefoot posting, which did improve the situation in terms of her pain. But of course, she continued to have instability. We tried physical therapy, focused on stretching her gastroc, working on perineal strengthening, stretching her tib post and dynamic stabilization, nice splinting to help the gastroc, and a lace-up ankle brace. In the end, she ended up requiring surgery. And in this case, as you know, she's forefoot and hindfoot driven. We ended up doing an endoscopic gastrocnemius recession, a percutaneous endoscopic lateralizing calcaneal osteotomy. Because we're lateralizing her so much, I do a subtle tarsal tunnel release. When I'm doing my calcaneal osteotomy, I want to make sure that I actually decrease the pitch a little bit. And I do dorsiflexion osteotomy of the first metatarsal with an endoscopic plantar fascia release. Then we deal with the soft tissues. Here, we ended up doing a right ankle scope, a dorsal talar ostectomy, taking away that cam lesion that Tim was talking about and that Alastair was talking about. And then we did an ankle ligament reconstruction and augmented with internal brace, as well as did a perineal double level transfer. So you can see here when you enter the case here, you can see some deficient tissue as you go in. You can see the perineal tendons, which are not looking very great. And you can see that here. And so what we're doing here is I do an approach where I do a modified technique. So you can see here that we have longus with left of it and brevis. We're going to tension longus tight, so we have brevis tight, in maximal dorsiflexion eversion, so that we can get this as best tight as we can. We don't have to rotate the clamp as much, just like that. And that's where we're going to be like that and transferring this over. Okay. So you can see here that we've actually identified that there's a perineal tear. We're doing a double level perineus brevis longus tendon transfer. The key here is that we want to distalize the proximal perineus brevis when we do the transfer proximally. Here I've used anchors in the ATFL and CFL, which I'm going to use a modified Mason-Allen approach to drive these to the common origin point of the ATFL and CFL. Here that longus has been tensioned down and brevis is now tensioned up, transferred to each other. We'll sacrifice the bad looking brevis here and do a second level transfer at this level. So I have blue, which is brevis, and that's longus. We're going to be tensioning brevis when we transfer it by giving it a bit of a tug. It gives us more power, like that, and we'll transfer it like that to our longus. Okay, so then that brings us to the actual ligament reconstruction component of things. You can see here that we've actually taken the tissues down. Moving through the CFL, it's actually this one here. with a Mason Allen stitch to give us our eversions. But the bigger problem here is actually the excessive anterior translation and rotation of the talus, which is due to the deficiency of the ATFL. Once we repair the ATFL, which has two fascicles, superior, inferior, and basets, so have a nice reduction to the common point. You can see here we have an ankle that was woven through. Sorry about that. And so then you can see that once this is reconstructed, you can now see that she's there. It's a nice isometric point. She's now stable, both anterior drawer and CFL. You can now see that she's. All right. So in the end, what you end up having is you have a nicely corrected hind foot, a nicely corrected midfoot, and you've corrected the ligaments as well as dealt with the accessory issues. Sometimes, however, it comes to the point that you actually don't have enough tissue presence at all, and then you may need to consider something either an allograft or autograft reconstruction, specifically when you start getting these patients that have had chronic instability with non-concentric changes in arthritis. And you can see that here, patient with non-concentric changes, medial impingement, lateral ligament chronic instability, and features of anterior ankle impingement, impingement in the back in this case, as well as here you can see a fairly neutral Mary's angle. Here we did a front and back approach to deal with the posterior impingement, anterior approach where we do a generalized cleanup of the anterior osteophytes, the dorsal talar cavum lesion, and the medial gutter impingement. And that's all done in a systematic type approach. And that's a cam lesion where you scoop out that neck, and that's something that Alastair and that Tim were talking about earlier. And then you come back and you reconstruct the ligaments. In this patient, because they have varus of the ankle, we also did a distal tibial osteotomy. But you can see here that you have the ATFL tunnel, the CFL tunnel, and we reconstruct these with allograft or autograft. And here you can see ATFL reconstructed, and then CFL reconstructed as it comes down behind the perineals in an oblique type fashion backwards under the perineal tendon secured with an interference screw. And that's the patient now compared to where they were before in terms of the concentricity. Finally, when we think about this, we also have to think with these chronic ankle instability patients, we also have a feature of perineal involvement. And one needs to really think about the perineals and how to deal with the perineals. It's always been my impression that the perineals actually hate having surgery, and I try to avoid operating on them as much as possible. I also find that if there's a way to make two tendons into one good tendon, then you have less going through that fibroosseous tunnel. So you can see here that there is that significantly flattened and shattered looking peroneus brevis with a thickened peroneus longus in the setting of this cava varus foot, right? So you have varus of the hind foot. Here, there's more varus of the hind foot than there is a problem with the actual midfoot itself. So here what we ended up doing is coming down, identifying the perineal tendons. You can see how bad that peroneus brevis looks. Peroneus longus here is actually elongated, right? And so you can see here how bad that peroneus brevis looks with the snap. Now that's debrided, and you can see here a terrible fraying and tearing of the peroneus brevis. So you weren't making up any of your symptoms. Completely torn, almost looks shattered in this area here. So we're going to do a perineal transfer up here, and one probably lower down because this is so that's what's done here. You can see here now that you actually come in. So you can see here this is peroneus longus here. You can see because it brings the first toe down right there. The first toe coming down right there. Move it there. Okay. And then all scarred up in here. All that was scarred up, we have to release it. We're gonna have to release more to have a look. And then you have this shattered, horrible looking, disgusting. So that's the bad peroneus brevis. So distally, you can see that we've tensioned brevis up, proximal transferred, and proximally we've tensioned brevis down and tensioned it. So now we have a nice correction of this, and we want to get rid of that intercalated segment. Finally, the end of my talk here is sometimes this is thank you to Dr. Eric Giza. Sometimes you have patients that actually have such bad tendons that you can't reconstruct them, and you need to think a little bit better here. This patient had surgery in the outside periphery, 46-year-old male, previous malleolus fracture, pain in the medial tibia and posterior ankle, had an ankle scope in the past with the peroneus brevis repair, hard removal, continues to have pain, new MRI is done, which shows again severe flattening of the brevis and some issues with the longus. And in this case, MRI shows that the tendons are severely scarred down. And here, Dr. Giza actually went in and he actually identified the tendons and made one good tendon out of two by reconstructing and doing an allograft reconstruction of the tendons and cable grafting this to the distal aspect. And this is one other way to consider doing something like this. So guys, thank you very much for having me. Key things are really think about these soft tissues when you're doing Cavus feet. Make sure you think about the associated pathology and treat the underlying alignments. So thank you.
Andie, we have a question asking, when you do a calc slide plus a lateral ligament reconstruction with perineal tendon work, how are you planning your incisions and your approach there?
Well, that's actually a very good question because I've been doing my calcaneal osteotomy through a minimally invasive scope technique for the last 12 years. So I don't really have to think as much about that. But if you're really thinking about doing both together, I tend to just extend my incision more posteriorly and bring a flap up. But I haven't done that in many years. Generally, what I do is a percutaneous technique for the calcaneus. And then I do my typical incision on the posterior border fibula angling to the base of fourth metatarsal.
That was excellent, Andie. Really good. I'm so glad you focused on the perineal tendons. I'm always amazed at how much pathology these Varus patients can tolerate. And I've observed in my practice that it seems as if the perineal tendon disease is the tipping point. When they rupture a tendon or decompensate on the perineal tendon side, it seems to be what pushes them towards a surgical solution for their problem.
I completely agree. Like I noticed that from my standpoint, I have very bad varus non-concentric arthritis patients that are super happy. They're so happy, and then something changes. Like, you know, they say, "Hey, I felt a pop or increasing pain to my lateral ankle," and then they completely decompensate. And they've had this kind of malalignment for many years, and all of a sudden something changes, and that tipping point is the rupture or the involvement of the perineals. And
it's a rapid decompensation.
Oh yeah.
Alastair is going to talk to us about the Taylor Valgus deformity. The reason I have a bias, I feel that there's two directions of forefoot-driven Varus feet go. In the ligamentously tight people, you know, the ones that could never do the splits, they tend to go into a varus tilt. And in the ligamentously lax forefoot Varus deformity, they tend to develop multidirectional instability with a valgus-Taylor tilt. So I've asked Alastair to talk about management of end-stage arthritis. I know that this is a sports session, but most of these patients are athletes, and they present in their mid-50s at relatively young age with trashed ankles that look terrible for 10, 15 years, and maybe they had a perineal tendon rupture, something happened, the scales have been tipped, and they come to Alastair for a solution. Alastair?
Thanks, Tim. Yeah, these we've sort of coined the phrase miserable heptad because it's like ankle instability, osteochondral defect, perineal tendinopathy, ray fractures, hindfoot varus, medial impingement. They're just nasty. So I'm going to talk about managing end-stage ankle arthritis with Taylor Valgus and Pez Cavus, when to fuse, when to replace, and whether to do one stage or two stage. I'm going to do it case-based, and you're going to see some of my successes and some of my failures. These are my disclosures. So the challenge of the Cavus foot is that malalignment causes arthritis. And if you don't correct the malalignment, you have a hard time dealing with the arthritis. So in end-stage arthritis, the correction of deformities is important as managing the end-stage arthritis. And the deformity can be corrected single stage or with arthritis. An excellent if we realign the guide of how to do this. Tim Andrew Dodd produced paper, which is approach on what when have wound issues, but if they're very, very old, in the same way if the activity level is very high or very low. And I also look at the ankle joint, and remember that an ankle joint replacement is a resurfacing procedure, and therefore you need to be able to restore motion. And if the medial and lateral malleolus and the ligaments are not going to work, then you can't essentially get any reasonable range of motion. The adjunct procedures are very important, whether you do them the same time or staged, including lateral ligament reconstruction, osteotomies, which can be medial malleolar, fibular, tibial, or calcaneal, fusions, so subtalar, talar navicular, calcaneocuboid, and first TMT will allow realignment. And you may also consider tendon lengthenings, tendon transfers, and deltoid or lateral ligament repairs, which I think are key in getting this to work. So staged or not, well, the foot can be corrected in 2 stages. You also need to ask, can the ankle be made functional and delay fusion or replacement? And the foot at the end of the day must be positioned under the ankle correctly for a replacement to work. This was a patient of mine who presented with a clubfoot deformity and a congenital fibular hemimelia. He'd had multiple previous procedures, and he presented with this deformity. And this sort of shows some of the challenges of the principles of realigning and getting things straight. You'll notice the Taylor shape here, which pushes the foot into varus. This obviously is a severely deformed foot. My plan was to do a triple arthrodesis by taking out bone and correcting the foot shape, plus do an ankle fusion. And also, because of this tibial osteotomy, revise the tibial osteotomy and correct the foot position, which is pushed way forward by the osteotomy. So the triple arthrodesis was done using a technique popularized by Mark Myerson, taking out bone on the subtalar joint at the TN joint and the calcaneocuboid joint to get this foot realigned underneath the ankle. And then the ankle is then brought to neutral, and then the tibia is then realigned to push the foot back. With reasonable position at the end of the day, although this tibial osteotomy has had challenges healing. This is a 2-stage procedure. This was a triple arthrodesis done arthroscopically and correcting some of the deformity of the foot, followed by total ankle replacement 4 weeks later to the recovery time down to 6 weeks. So if you're thinking of staging and getting the patient mobilized quickly, this is one alternative. This is another case separated by 10 years. So the patient had an ankle instability. You can see here the extra bone between the talus and the fibula, with obviously deficient lateral collateral ligaments, erosion of the medial side of the talus and the distal tibia. I did a calc osteotomy and lateral ligament reconstruction. This gradually failed in time. And so I did a total ankle arthroplasty, a subtalar fusion to correct the deformity with bone out of the subtalar joint, and a medial malleolar osteotomy to correct the deformity with a lateral ligament reconstruction and a lateral gutter debridement with successful correction, single stage. This is another case, a patient who had increasing hindfoot varus deformity. By 2012, he looked like this. Again, you can see debris in the lateral gutter, deficient lateral collateral ligaments, a tight deltoid ligament, and lots of extra bone around this ankle joint. So I used the lateral approach ankle, and this shows how we can correct the deformity. So this was where he was articulating before. This is where he's going to articulate now that I've corrected the ankle with a bimalleolar osteotomy. This is what it looks like after I have transfixed the lateral side and the medial side, a subtalar fusion, taking out some bone on the calcaneal side to realign it. You can see again, this ankle is not coming straight because there's a bone in the lateral side that needs to be removed. And with that, in the lateral reconstruction, I was able to successfully realign this foot. So this was single stage intra-articular correction plus extra-articular correction in both the forefoot and in the subtalar joint. This is a case I did with a case that simply was never going to take an ankle joint replacement. There's just no way of restoring function here. This is an old fracture with a cavus deformity. And so in this case, I did an arthroscopic fusion, but I also put bone in the front of this ankle to restore the position and get the foot flat to the ground, again with a subtalar fusion to correct the shape of the foot. This is a patient who I saw in 2011. He had ankle instability in a cavavarus foot. And I did an osteotomy. So I corrected the foot shape. My criticism here is that this talus is laterally translated. And ideally, I should have corrected this more through the cora. It also required a dorsiflexion first TMT fusion. This staged this guy until 2019 when he returned with post-traumatic deformity. So I took out the hardware and then came back and did a total ankle. Now, fuse or replace. Well, what makes a replacement harder? In fusion, you only got 12 errors you can make in 3 planes of rotation and 3 planes of translation. But replacement has 40 potential errors because there's 3 planes of rotation and translation of each component, as well as the relationship of the components plus 6 size errors. So each component can be too big, too small, and the polyethylene can be too big, too small. So there's lots of errors you can make in total ankle, and you got to get it right. And so this shows some of my planning. So obviously this talus is too lateral, and we need the talar component underneath the long axis. So this medial malleolus actually has to translate medial to get this. The lateral mal come back over. So I did a bimalleolar osteotomy, translated the ankle back under the long axis of the leg, pushed the fibula medially through the fibular osteotomy, and got this back underneath, and this gentleman's enjoying reasonable function. This is another case with non-concentric arthritis and a valgus hindfoot. Again, the medial gutter filled with debris. Impingement here, so the foot tries to correct, and we get sort of a double or a Z deformity. And in this case, I was able to get it without a medial malleolar osteotomy, but correcting the foot. And no subtalar fusion or calc osteotomy. This was a challenging case, an old tibia fracture with the foot anterior and into cavus in position. So 2-stage, single-stage tibial osteotomy or not was my debate. This is what I ended up getting. I put the foot underneath the long axis of the leg, cut out bone here and moved the medial malleolus laterally, as well as on the tibial side, moved the tibial component posteriorly. So this was actually my surgical plan, taking out bone in the lateral side, bringing things over here, bringing the fibula over, and correcting it in the frame, bringing the talus posterior here. This sort of designed my cuts, and translating things over. This is what a tibial osteotomy would have looked like, and it really would have been a much harder operation. So I elected to do this single stage and simply bring the ankle under the long axis, translate things over, and get things corrected with an end result that looked like this and the foot flat to the floor. This is an arthroscopic ankle fusion in Varus. And unfortunately, this gentleman, I didn't correct quite enough. He got impingement on the outside of his subtalar joint. I had to take him back. He's better, but ideally I should have corrected this more. This is another case where we've got a pretty destroyed talus. I felt that I could salvage this with a total ankle based on the CT. So it is similar to that previous lady. I translated everything posteriorly and laterally and got the foot underneath the long axis of the leg successfully. This is a gentleman who's a smoker, and I tried to do a medial malleolar osteotomy. I didn't correct it enough. I had to go back and take out some of this talus, do a subtalar fusion to get things back where they belong. So in summary, correction of the deformity is critical. The treatment of the ankle arthritis is almost secondary. Staging may be determined by your ability. It's better to stage and achieve the goals than fail single stage. You might have to prolong the patient's recovery time. That's okay, but get it correct. And don't plan 2-stage too close together because of wound issues. And technique can allow correction of complex deformity single stage. So thank you, Tim. Thank you, Selene. Hopefully that was what you're looking for, Tim.
That was excellent, Alastair, and thank you for staying on time. Alastair, Ted Hansen, I don't know if you remember, used to emphasize that if you want to understand pathology, look at the end stage of the disease and work backwards. So, yes. You know, one thing that I've mentioned after the previous talk, and it's even more evident in yours. Why do these 4-foot-driven varus ankles present so late in their disease pathology? Like I look at these X-rays and I think these X-rays have looked awful for 15 years. Why is this patient coming in now and asking me to do something for them? What's going on there? Do you have any insight on that?
I think, you know, part of it is that these patients are athletes, and they learn how to tolerate pain, and you know, they just keep going at it. And I think the thing that happens, they reach a point where things become unstable. And as Andy and you've pointed out, perineal tendon rupture is sometimes the point that they tip out of control. I think also when they reach a point where the center of a cumulative center of joint reaction force falls outside the ankle joint, at that point it becomes an unstable equilibrium and everything just falls in. So what I've learned over time is that you've got to restore things back to an absolute neutral position. And anytime I failed in these reconstructions, it's usually because I haven't got the foot back underneath the long axis of the leg. And it's usually because I've undercorrected these cavus feet that are just extremely hard to get back. One of the things I've observed is the talus is very different shaped in these patients, and it's probably part of the original driving force in them. And they have this block-shaped talus that can almost tilt towards the medial side. And if you look at the plantar valgus feet, it's completely the opposite. And the answer lies, this blocks the subtalar joint going back out. And I think the answer lies in many of these are doing a subtalar fusion, but also with a fair amount of bone removal on the lateral side. And if you're doing it with a total ankle, you don't want to compromise the blood supply in the talus. So the bone needs to come out in the calcaneal side. So that's kind of what I've learned reconstructing these patients, and where I've made my error is underestimating the cavus driving force of that sort of block-shaped talus.
Thank you, Alastair. You'll have to stop sharing so I can share my screen.
Okay.
So I'm going to talk about the Taylor Valgus, and I think it's important to understand that these patients are starting with a similar etiology, and that is that they're not balanced through the forefoot. They're preferentially putting weight through the lateral bore of the foot their entire lives. Many of them are athletic. Many of them have already had a lateral ligament reconstruction, and then they present later on in their 50s and 60s with this decompensation that we've all been referring to. For the young people in the audience, it would be very useful to find the pathophysiology that results in the situations that we're talking about. My disclosures for this talk is that I am on the design team for the Cadence ankle, and I do receive royalties. So this is a lateral X-ray, and earlier on in my career, I would look at this X-ray and say, well, that's a severe pes planus deformity. If I showed you the AP of this patient, they're in approximately 20 degrees of valgus. But I challenge you that this actually wasn't a pes planus deformity, particularly if you look at the other side, if it's non-pathologic. These patients started with a forefoot-driven cavo varus deformity. And I hesitate to say deformity because, as Rachel said, 25% of people have this shape as part of their foot anatomy, and they've all been extremely athletic. In fact, I think there's a propensity for patients with this shape of foot to be more athletic than the flat foot patients. But nonetheless, gradually over time, they've lost support and have collapsed. My bias is that we don't look at the deltoid ligament enough, that part of this decompensation is deficiency of the deltoid, combined, as I already mentioned, with generalized, and I wouldn't say severe ligamentous laxity, but these patients tend to be more lax than the subset that Alastair just presented, who also started with a forefoot-driven cavo varus deformity and presented with a severe arthritis and varus deformities of the tali. So if you look at this patient on the left side of your screen, they're presenting with Taylor Valgus. There's some dysplasia of the malleolus. Again, at these end stages, look for dysplasia of the malleolus, either medial, lateral, or both. There's a little bit of widening of the syndesmosis, but look at it at his other side. I would say a subtle forefoot-driven cavo varus deformity. He had a severe sprain when he was young playing football on the right side, and that's the only injury he had. On the left side, he never injured that side, and he presents with this Taylor Valgus deformity, exposed Taylor head. And many people would look at this and say, well, that's a stage 4 flat foot. It's not. This patient had a forefoot-driven cable varus deformity that over the years decompensated. I like to talk about multi-directional instability, and I'm going to be talking tomorrow with the Chilean group about my multi-ligament reconstruction procedure. Here's another patient where the once again, they started with a cavus foot. They still have a cavus foot, but they present looking flat. This talus has gone into valgus and is actually translated posteriorly. Once again, if there's any sagittal displacement of the talus, either anterior or posterior, in my view, that is multidirectional instability of that ankle until proven otherwise. And the vast majority of those patients started with a forefoot-driven cable varus foot. This gentleman is a police officer, and once again, he injured his right ankle. It was a soft tissue injury. He didn't have surgery. You can see that he actually avulsed a fairly large chunk of his medial malleolus. So he suffered a deltoid injury, a lateral instability as well, and once again was tolerating a fair amount of pathology and went on to develop this Taylor Valgus deformity. If you look at the lateral x-ray, you can see it looks like a pes planus foot, but if you put all those pieces back together again where they used to be, he's actually got a more of a cavus foot. Selene, I understand that I'm running short of time, so I'll go through this very quickly. Hind foot alignment views, and now as Rachel has eloquently discussed, the weight-bearing CT scans are very useful. If there's a decoupling between the talus and the calcaneus, in my hands, nothing short of a subtalar fusion can get that calcaneus underneath the talus. And again, here's another patient with bilateral valgus ankles. He comes in with really flat feet, but once again, he started with a forefoot-driven cable varus deformity. Look at the AP view of his foot. There's no forefoot abduction. This is not a stage 4 flat foot. This is a multi-directional cable varus deformity that has decompensated. This is Beat's slides, and I had permission from him to use them. But look at the bottom left picture. There's about 20 or 30 degrees of valgus there. And when he brings him to the operating room, he puts in a laminar spreader and corrects the Taylor valgus. And these are the pictures on the right where he hasn't corrected the Taylor valgus. And the bottom picture on your right is where he has corrected it. On the left side is the fibula. Look at the varus of that hind foot. This looks like a stage 4 flat foot, but it isn't. And it's so important to recognize this because the reconstruction of this deformity is far different than a stage 4 flat foot. Very often when you balance that ankle, you're dealing with a cavus foot underneath the ankle once it's balanced as opposed to a flat foot. This is a patient that presented to me. We don't have enough time to discuss. I'd be interested in how many people would consider a salvage of this ankle as opposed to fusion or arthroplasty. But look at the malleolar dysplasia. It's almost like there's no medial malleolus there. I know that's part rotational. There's the lateral view, Taylor valgus, but cable varus. And in this scenario, I went ahead and, sorry, I'm just quickly showing a true stage 4 flat foot and the difference between them, but I'm rushing through this because we're out of time. Nonetheless, in this patient so on the patient on the left is a stage 4 flat foot. On the right is a forefoot-driven cable varus with Taylor valgus. Same thing, forefoot adduction in the stage 4 flat foot, not in the Taylor valgus with a pre-existing varus, forefoot-driven varus. But nonetheless, in this patient, I went and did an ankle arthroplasty with a dorsiflexion osteotomy, the first metatarsal, a lateral ligament work, as well as perineal work. Maybe I should have done a fibular osteotomy to deal with the dysplasia of that fibula, but in this case, I didn't. So this is a very broad topic, and I'm just going to stop sharing here so we can get in the proper views. This is a very broad topic, Selene. I hope we touched upon the salient points, and thank you very much for inviting us to this excellent webinar.
Yeah, I'm sorry to be so strict on the time. We just set all the programming, as you know, 24 hours, we're trying to make it on time. But thank you guys all for being part of it, and most of you we're going to see again later in the 24-hour period. So get some rest, and I'll see you later on. Thanks to Paragon 28 for the session, and thanks everybody. We'll start the next session in a minute.
Thank you.